So the next presentation is by Rongjia Liu from University of Alberta. Consensus generation in pathology, mentoring aspect and how rules are established, an example of Banff transplant pathology in discussions.
Oh, here we go.
Yes.
Okay. Your fault. Thank you. Okay, good morning everybody. Thank you for coming to my talk. Today I'm going to talk to you about consensus generation in pathology. Okay. So what is consensus decision making? According to the Merriam-Webster dictionary, consensus means a general agreement or the judgment arrived at by most of those concerned. And it is a group solidarity in sentiment and belief. So it is a process that's used by groups of people that wish to seek to generate widespread levels of participation on set topics of discussion. And it's a highly effective decision-making method. It's kind of the opposite to debating, where people usually go in arguments and pick out one idea versus another. Consensus is you gather together and try to set on a agreement or like a compromise that the whole group agrees with. So it's commonly used in pathology. So in traditional consensus facilitation, the consensus facilitator is usually a professional that has a trained and certificate, and usually the facilitator would be a neutral third party who has skills in facilitation but no knowledge on the topics of discussion. However, in pathology, many times that's not the case, because many times usually the facilitator is also a well-known physician or the leader of the group. So in the example of Banff conference, which is run by Dr. Solas, he himself serves as the facilitator along with Dr. Advocacy, who is also a well-known pathologist. So there are also leaders in the group. However, is there a way for experts in the discussion topic to also act as the consensus facilitator? And the answer is yes. So there is a book published, it's called Listening with a Point of View. It's called Facilitator's Guide to Participatory Decision Making, and in it introduces a method called Listening with a Point of View by Sam Connor. So today I'll talk to you guys about this method on how to generate consensus using a facilitator who's also an expert in the field. Okay, so listening with the point of view answers the question, how does the expert promote his or her own point of view effectively, but while still making room for all other opinions to be voiced? It keeps the person's two roles in balance, because the person who's acting as the facilitator must have two mindsets. They must first have the leader's mindset. So as the leader of the group, they have to be responsible for clarifying his or her own thinking and express their own point of view effectively. However, as the facilitator, they must care about helping the group to do its best thinking, wanting to support others to develop their lines of thought. So it is a five-step process with the listening with the point of view method that will support this person to balance both roles. So step one is to first just raise the issue that is to be discussed, and then simply state your position. Then step two, ask for reactions from the audience. So give them some time to express their sides of view. And then step 3 is to respond to the participants' comments as the facilitators would. So in this step, you want to just really take the time and listen to everybody's sides and paraphrase people's viewpoints and draw people out, and lean more on the side of drawing people out, because many people find it hard to challenge your authority because you're the leader of the group. They find it hard to give points of view that may be opposed to yours. So you need to give them extra support to voice a differing opinion. Okay. And step 4 is, after at least 2 moves of facilitative listening, you can now give yourself the floor to speak. So make statements that reflect your own perspective and explain why you believe the way you do. And also answer questions and provide information and explain and just advocate. Okay. So step 5, or the last step, is to just repeat step 2 to 4 as needed to generate more and more discussion. So remember to always balance speaking your own opinion with at least twice as much as listening, because we have 2 ears and 1 mouth, so that means we should listen twice as much as we speak, especially in this case. Okay, yeah, that's all I have for you today. Thank you for your time. Yes, please.
Very nice structure, spelled point by point process. We do it, but we never pay attention how it is done. So
Yeah, I mean, if you talk to a professional facilitator, he says what we're doing is illegal and, of course, contrary to what they learned in school, that you don't need to know anything about the subject. And you assume that every subject is sort of life and death and its consequences, so the people who actually know the field will be so incredibly biased, that none of them can be, objective decision makers. Whereas actually, anatomical pathology is a pretty tame field where it's not, for us, life and death, where we can probably provide, reasonable middle ground views. And what happened at the very first meeting in '91 was very interesting. I mean, there were only 21 people at that meeting. And a lot of us brought some sort of construct there. And at the end of the first day, people came to me and said, "Kim, I'm so sorry. This meeting is obviously a complete bloody failure. You put so much time into this, I feel so sorry for you to have led such a completely unsuccessful meeting." I thought, well, gee, I didn't really notice that. So the next morning, I got up early and put on the blackboard a kind of combined construct that seemed to represent the strongest points of view and the best ideas that people had the previous day. It bore no resemblance to any construct anyone had come to the meeting with. And people came in and looked at it and said, and the rest is history. But that lack of macho sticking to your guns and, you came with a piece of paper, you're going to make that piece of paper the classification. If I had done that, the meeting would have been a complete failure. So, I honestly think it's not very satisfying, and most of you have been envisioning situations exactly like this, where the person in charge knows nothing about the subject, but is teaching you this new creative way of thinking and putting post-it notes on the board and so on. And it doesn't seem to me that is the best way. When you can have somebody leading discussion who actually knows about the subject seems to be infinitely better. So anyway, that's what we've done over the past 24 years. Yeah.
Yeah, I fully agree with you. And in a way, you know, these people who construct things remind me of that comedy of Molière, that the bourgeois who now he understands that when he speaks, he makes prose.
Yes.
So,
Yeah. So,
Next presentation.
okay, yeah. Korey Fung has the next presentation.
The genomic pathology and tissue engineering pathology compared and contrasted from University of Alberta, Canada.
Okay, thank you very much. As you can see, my title is, in fact, actually Dawn of Tissue Engineering Pathology and the End of Transplantation of Waiting Lists. I apologize, you won't actually find any genomic pathology in my presentation. There was a change to the program, and I suppose this change didn't make it in. But I think you'll all enjoy the presentation I have following, so let's move on. So the current problem with end-stage organ failure is that the gold standard right now is transplantation with a donor organ. Unfortunately, as stated before, this only reaches 10% of patients. Unfortunately, as a result, there are thousands of patients that die every year simply waiting for the chance of a transplant. The solution is tissue-engineered organs. So we already know what these are. We've talked extensively about them this morning, so I won't go into detail, but it's suffice to say that tissue-engineered organs will effectively replace the need for donor organs. Now, I wanted to highlight some successes in the tissue engineering field so far. There's been great success with simple tissues. What I have here is airways, bladders, and down there at the bottom I've highlighted the ViaCyte VC01. This effectively replaces the pancreas in type 1 diabetes patients. It consists of a synthetic encapsulation, and inside it has been seeded with cells that mimic the functionality of beta cells of the pancreas. As you can see here, lots of these are semi-synthetic, and this would address the question that I believe Dr. Jackman had earlier about the structural integrity of the tissues. Many companies are using semi-synthetic scaffolds, so they're seeding silicone tubes, carbon nanotubes, so these aid in the structural integrity. The only problem that I have come across with these in the literature is that semi-synthetic scaffolding are prone to infection. And for that reason, there are many companies that are looking forward to 100% organic scaffolds. So I'm hoping in the future that the success of tissue engineering will provide more opportunities like this. This being the chance for transplantation teams to scrub in and give more people replacement organs. But this is a pathology conference, so I wanted to think about what is the role of pathology in the emerging field of tissue engineering. When tissue engineered organs come out, they're not always perfect. There are many abnormalities that come along with them, and it is the role of pathologists such as yourselves to identify and assess these abnormalities. I've thought of two kinds of abnormalities here. One of them is the one-off abnormality. I describe these as abnormalities that appear in the organs simply due to the certain technique of developing the organ. And once identified, these abnormalities will not be occurred again, because then the companies developing the organs will realize that that abnormality was only because of a certain technique used. Secondly, these are the ones that pathologists will most likely come across in the field. These are repeating abnormalities, and I'll outline them as follows. So here, this is an abnormality observed by Song et al. In rat kidneys that were tissue engineered, and they observed that sometimes there are cells that appear in places they do not belong. So I'd like to draw your attention to the top left-hand square that says podocin. So that outlines podocytes that have moved into the interstitium, and normally podocytes would never be found in there. Secondly, this is something observed by Chang and Davies. As you can see, when they had created a tissue engineered kidney, sometimes it is missing vital structures. So as you can see on the right, it is missing the loop of Henle. So this is also an abnormality that can be seen in tissue engineered organs. Not specifically that all will be missing the loop of Henle, but I want to point out that it is the sometimes structures that can be missing. When we're looking at tissue engineered organs, I believe rejection will most likely be unlikely because the tissue engineered organs will be built from the ground up using stem cells that are from the patient themselves. Because of that, the tissue engineered organs will be syngeneic with the patient, and I believe because of that, rejection would be unlikely. But pathologists need to also remember that tissue engineered organs will be subject to conventional disease, just as non-tissue engineered organs also are. Because of that, I believe in the emerging field of tissue engineering, pathologists will have double the workload when it comes to assessing these organs. I also wanted to introduce an idea I had on possibly how to classify tissue engineered pathologies. I wanted to base the classification on the ability for abnormalities to disrupt the function of the tissue engineered organ. The first criteria would be benign criteria. These would be abnormalities observed in the tissue engineered organs that would not severely hamper the functionality or would not cause any difference at all. And if the organ was deemed to only have benign criteria, it would be safe for transplantation into patients. Conversely, you have potentially lethal criteria. These criteria would obviously cause severe defects in the organ, and as such, if it was deemed that the organ only had these kinds of abnormalities, it would be unsafe to use in patients. To that end, I believe a point system could be used. A point system is common in many classifications in the pathology field. Benign criteria would be assigned negative points. Potentially lethal criteria would be assigned positive points. The summation of these points would help us classify the variants. And as the classification develops, I'm sure that there will be certain danger zones, borderline zones, and safe zones that will become known. So the very also novel thing about tissue engineering medicine is that it will be the first field of pathology that will be 100% quantifiable. This is because the use of biomarkers, I believe, will be a very large force in the emerging field of tissue engineering. Biomarkers themselves are quantifiable by nature, and as technology is advancing rapidly, morphometry for assessing tissues is now a very feasible option. So like I said before, algorithms will be developed. We won't be using arbitrary scales anymore. The algorithms will be developed by using sophisticated computer software to assess all of the mass amounts of data that are emerging inside this field. And the complex computer software now can do what is come to be known as big data mining. And this allows people to put vast amounts of data into computer programs and allow the computer programs to assess the data and come up with something that is meaningful for people such as ourselves. Now, the ability to have computers create algorithms for the classification of tissue engineered pathologies is completely different than previous classifications, such as the Banff classification, where Banff classification was only semi-quantifiable, and there were still so many things that were at the discretion of the pathologists examining those kidneys. Now, I spoke a lot about biomarkers and how they're going to be used, and I wanted to point out that biomarkers will in fact be used to assess the health of tissue engineered organs. In many tissue engineered organs, like the bioreactor I discussed earlier, cutting into them would be far too invasive. If you were to cut into a bioreactor, it would automatically expose the cells inside the bioreactor to the autoimmune functions of the body and would essentially destroy the bioreactors. So that can't happen. So instead, the use of biomarkers in the fluid surrounding tissue-engineered organs, I believe, would be a very useful, non-invasive approach to assess the health of tissue-engineered organs. I've given one biomarker here as an example. It's called the KIM-1 biomarker, kidney injury molecule 1, and it is used right now as a indication of renal proximal tubular injuries in kidneys. And I believe biomarkers such as these, if they can be used in conventional, non-tissue engineered organs, they can most likely be used in tissue engineered organs of the future. Now, this is a rapidly advancing field. It's my belief that tissue engineering should be brought into the mainstream, and that all pathologists should be at least exposed to the capabilities of this advancing field. And how are we going to do that? Well, I believe conferences such as these that focus on emerging technologies instead of just present technologies is key. Advocacy is key. And as a student myself, I have seen the benefits of having courses within universities that focus on emerging technologies, such as the one that is taught by Dr. Solos at the University of Alberta, the technologies and the future of medicine. I think it's a novel course that encourages medical students, or any students for that matter, to not only think about future technologies, but also to challenge the limitations that are placed on us right now from our present technologies. And as the field progresses, the pioneers of tissue engineering pathology, which could be, like ourselves here, the first people to really talk about this, we will become the pioneers in the field and the experts in the field, and it would fall on the responsibility of, like you all here, to then teach future generations on the capabilities of tissue engineering pathology. So I'd like to leave you all with this, is be at the forefront of something that is going to completely revolutionize the field of medicine, and it's going to completely revolutionize pathology specifically. So I implore all of you to give it some thought in the future and see where you can get a foothold in this emerging field. Thank you. I will take any questions now if anyone has them. All right, thank you very much for your time.